Perfect. So let's begin. I really tried to sum up all the pediatric diffuse gliomas, high grade, into one presentation and one Zoom session, but uh, I am not sure if I'm happy to say that I could not, because we are still going to be left with one more subtype even after today's session that we will wrap up tomorrow, inshallah. So, without further ado, all of you remember that we have covered diffuse midline gliomas, H3K27M altered already. Okay, and apart from this, we are left for three more tumors. The first one is diffuse hemispheric glioma, H3G34 mutant. Then we have diffuse pediatric high-grade glioma, H3 wild type, IDH wild type. And then in the end, we have infant type hemispheric glioma, which we won't be covering today. So I have a very interesting scan for all of you, and I would be very happy if some of you can volunteer. What do you think this is? Do we have volunteers with us?
Assalamu alaikum.
Walaikum assalam, Dr. Sana.
Yes, Dr. Kamal, can I proceed?
Yeah, sure, you can.
This is a hypo intense. This is an MRI brain with axial section showing an hypo intense lesion in the left frontal area, well circumscribed and having some uh, central vascular fluids and pressing the ipsilateral ventricle and causing mass effect and midline shift.
Okay, Dr. Sana, it's the safest approach to describe any lesion on an MRI is to never comment on vessels when you are talking about T1. But that's okay. This is a discussion session, so these things are
Okay.
allowed. Don't do that in a formal clinical session. So, yes, we have an axial section, MRI, brain plane. These are T1 weighted images, and we can see an iso-intense lesion, which is somewhat circumscribed. This is not completely, we would not call this well circumscribed. This is somewhat circumscribed and iso intense because if you see, this is very similar to the intensity of gray matter here and showing some central cystic regions. Why cystic? Because these are resembling the intensity of ventricles here. Okay. This lesion is causing significant mass effect. It's causing herniation, midline shift, effacement of ipsilateral lateral ventricle. We also see that ACA, distal ACA, is also displaced here. But even though I said that, I stand with my initial statement. Do not comment on vessels when you are talking about T1. So, you see that this is an iso-intense lesion. It's more or less circumscribed lesion, iso-intense, homogeneously iso-intense. What does that make you think of? And the location is pretty typical. It's parafalcine. What do you think this could be?
Uh,
What's your first instinct?
hemispheric lesion. Uh, I-
Do you think of
um,
meningioma when you see this?
yes.
Would that be your first instinct if you didn't know that this was a class for pediatric diffuse high-grade gliomas?
Yes.
Because interestingly, that was my first instinct as well. And while I was making presentation for today's session, I realized that this is exactly the kind of lesion I received in my long case during FCPS part 2 very recently. And it was the same case. I had a very young patient, 21, 20 years young male, and he had Jacksonian seizures. He had opposite side weakness, and I was so sure that it was parafalcine meningioma. And they showed me the scan. They gave me the non-contrast images first, and it looked exactly like this. Very circumscribed, iso-intense, homogeneous looking, some cystic regions, and I proceeded with the impression of meningiomas. And then I asked for contrast images, which is what you can ask me too. So, on the contrast images, this is what we see. What do you see?
It's an heterogeneous contrast enhancement in the
Yeah, and what
lesion.
kind of contrast enhancement would that be? It's patchy as well. It's
Patchy.
heterogeneous and it's patchy. There are two different patches here and here. And contrary to what we were expecting, because the first impression when you see this, you expect a meningioma. So you expect a homogeneous contrast enhancement, a densely enhancing lesion, which is compressing the ventricles and causing mass effect. So we see that this is associated with with the fox, but contrast enhancement is not favoring meningioma, right? And uh, we can see that there are some cystic regions here and here. The further radiology of this case is ahead. So, if this was a patient in your OPD, 21, 22 years old male, having this form of lesion, what would you think? And how would you manage?
Uh, 21 or 22
Yeah,
years.
21 and
Uh,
22.
we will perform uh, according to the symptomatic management, and then we will do the um, uh, uh, venogram, MRV, or then we will proceed with the maximum safe resection.
Yeah, I get that. So, because that is exactly what I did. And what happens is when we receive a 20, 21 years old male and with this typical location, yes, we first think of meningioma. And then if we see this imaging, we might think of gliomas, maybe some low-grade glioma that is not taking up contrast. And that is our first instinct. We never think of pediatric gliomas, do we? This is a diffuse hemispheric glioma, which is supposedly a pediatric type H3G34 mutant. And these are WHO grade 4 tumors, contrary to what it looked here, because if you see the contrast enhancement and you don't have pediatric diagnosis in your mind, you're thinking of this as an adult glioma, then what would you think? This is probably a grade 2 or grade 3, maybe grade 2 astrocytoma, right? Because you see patchy uptake of contrast and the lesion is diffuse. So if you think of the astrocytomas, the just give me a minute. Please be quiet. So if you see this lesion, you would think that this is an adult type astrocytoma, most likely grade 2, especially if the patient is 20, 21 years old. So what happens is H3G34 mutants are the tumors which can affect adolescents and young adults. And when I say young adults, 20, 21, 22, this is a very likely age group. So the next time when you receive such a case in such age group, keep your mind open for a pediatric variant as well. Because we might go in the surgery thinking that this is a low grade tumor, but it might turn out to be a WHO grade 4, right? The median age at diagnosis is typically between 15 and 22 years. These are exclusively supratentorial cerebral hemispheres, primarily temporal and parietal lobes, and usually present with a very short history. Patients will tell that they have new onset seizures. A lot of times, these seizures are secondary generalized or partial seizures. We can have focal neurologic deficits. The patient that I saw had limb weakness and his leg was it was weak. The power was reduced to probably 3 or 4 by 5. So you can see focal neurologic deficits. You can see signs of raised ICP, headache, nausea, vomiting, etc. Now, I have just repeated this same image. Now, if you see and if you keep this picture and this age group in mind, I am sure that you will find a lot of patients in your clinical practice that are relatable. So, these are the sagittal sections. Can someone describe the sagittal imaging, please? Anyone? Okay.
Dr. Kamala, if no one is there, then
Yeah,
I
Dr.
can
Sana, sure,
try.
sure. You can. Whoever volunteers,
Yes.
it's their own benefit because you would get in habit of repeating the scans.
Okay,
Okay, Dr.
thank you.
Sana, proceed.
Yes, yes. This is a T1 MRI sagittal section showing an iso intense lesion with the central hyperintensity. Um, this is well circumscribed in the uh, uh, frontal lobe of the and frontal lobe and uh,
Yeah, and what do
com-
you see on the lesion, inside the lesion?
hyperintensity.
Yes, this is T1 weighted images, and there is hyperintensity in the lesion. What does that make you think of?
Cystic.
Necrosis.
This is blood. Who said necrosis, by the way? I'm happy that someone else volunteered as well.
Hamad.
Okay, Dr. Hamad. No, this is not necrosis, this is blood. And this is T1 weighted image. And what else do you think is happening here? Mass effect?
Yes,
Yes.
definitely on the motor areas.
Yeah, and the lesion is above Sylvan fissure, which we can see. It's very clearly above. There is involvement of, most likely involvement of motor strip, some secondary motor areas as well. And if we, I don't think I have axial of this. Yeah, so this is the axial. What do you think?
Yeah, it has a dual nipping. Looks like extradural indenting into the brain parenchyma. It's kind of confusing.
Yeah, so that is the point because we are very used to seeing these imaging in 2021 age group and we don't immediately think of pediatric type, right? And when you look at them, they do look as if these are extraaxial tumors and they look well circumscribed, sort of broad-based. They are touching the meninges here. And sometimes there might be a CSF cleft sign as well, which is also false localizing. So this is another imaging. Can someone else volunteer? Or Dr. Hamad, if you want to continue, I'd be happy.
Yes, ma'am. I have been providing multi-planar, multi-sequential images showing on T1. It shows yes. On T1, it is showing a well circumscribed heterogeneous mixed intensity lesion in the frontoparietal region, right posterior frontal region. It is it is it is also hyper and mixed exogenicity, mixed intensity on T1 and T2 both, and it is showing central areas of central necrosis as well.
Okay.
And
So,
that's
what is
and
that?
just simply sure that's all I got.
Yeah. Okay, let's go back to some anatomy first because this is a beautiful looking lesion. And yes, I am pathologic enough to call lesions beautiful, but this is beautiful in the sense that this is involving temporal lobe along with the posterior parietal lobe, inferior posterior parietal lobe, which is the typical area of this is right side, by the way. This is not left, but if this was left, what would this be?
Any
Okay.
hint, ma'am?
Okay, when you see that any gyrus that is following Sylvian Fisher here, if you can you all see my cursor?
Yes.
So this is where Sylvian Fisher usually is. You can see the MCA branches living here on T2 weighted images. And if we follow the Sylvian Fisher here in our own imagination, we see that this is going to be the region of supramarginal gyrus and angular gyrus, language cortex. And this also looks to be encroaching the at the inferior portion of the motor cortex and the inferior portion of the primary sensory cortex as well. You have to imagine this location in your head. If this was normal, Where do you think this would be? So these are T1 weighted images, post contrast, all these three, A, B, and C. And these are D and E are T2 weighted images, F is perfusion weighted. So A, this is a well circumscribed lesion, yes, not taking up enough contrast, a very patchy enhancement somewhere, and this is poorly enhancing tumor. When we see poor enhancement and a lesion looking like this, the first thing that comes to our head is this might be a low to intermediate grade lesion, right? We don't think of high grade immediately because if this patient is 20, 21 years old and you look at this, you might falsely assume that this is grade 2 astrocytoma or maybe oligodendroglioma. You would not think of grade 4 while you're looking at this imaging, right? Then we have T2 weighted image. Do you see the cystic portion? And then this is a beautiful tumor. Anyways, you see here, these are the MCU branches, Sylvian fissure, and good thing is that this lesion is on the right side. If this was on the left side, patient would have very strong language deficits. So on perfusion weighted images, we don't see enough perfusion going on in the lesion. Histologically, these are the tumors which are very similar to peanuts. Radiologically, contrast enhancement is minimal or patchy, which I have already elaborated. There is diffusion restriction. I did not find DWI images, unfortunately, but there is a diffusion restriction in them. Why is that? Because these tumors are densely cellular, they have small cell bodies, and that is why they are high signal on DWI and low signal on ADC. So there is frequent contact with the leptomeninges or ependymal surfaces, which is, if you see, there is frequent contact. These are either in association with the ventricle or in association with any meninges. Okay, so that is also falsely deceiving because it might look like the lesion is extraaxial. What is the only clue when you look at this imaging? The only clue is age, right? Because otherwise, if you receive this lesion, you are going to think grade 2 or grade 2 mostly because there is no enhancement. The only clue that this might be grade 4 is when the age is around 2021. So the treatment and prognosis. Surgically, GTR is the strongest predictor of improved survival, and GTR is possible because these lesions do give up a good plane, and also because they are small, the cells are small, they are densely cellular, so they look different on the visual analysis while we are resecting them. They look different than the normal brain matter, and that is why GTR is an option. Postoperatively, we send these patients for radiotherapy, standard focal radiation, usually 54 to 60 grays, and that is administered postoperatively. And chemotherapy, the TMZ is given usually because they are very responsive on TMZ because of MGMT promoter methylation. Prognosis is 18 to 22 months, roughly similar to adult GBMs, but this is a classic example of radiology belying the actual prognosis. And there are some newer targeted therapies where research is going on, and these are PDGFRA inhibitors. You don't have to know all these names, but you should at least be aware that there is targeted therapy and clinical trials going on. And there are CDK4 and 6 inhibitors. So, this is the H3G34 mutant. We move on to another interesting tumor, which is diffuse pediatric type high-grade glioma. These are H3 wild type and IDH wild type. So, how many of you remember that there was another pediatric tumor which was H3 wild type and IDH wild type, but I said that it was low grade? Does anyone remember the name of the tumor?
Mm,
Madam, oh sorry, Dr. Kaval, MYB and MYBL.
Yeah, that one, and there was another one. Yes, MAPK pathway, Dr. Fatma Javed, right? I'm happy that you people are remembering something. This is very dry stuff. So, Yes, the diffuse astrocytoma, MAPK pathway altered, and MYB, MYBL altered. These are also lesions which are H3 wild type and IDH wild type. So why are they grade 1 and this is grade 4?
Uh, because their behavior is very benign, ma'am.
Yes, because in pediatric oncology, IDH, let's go to that slide. I think I have that slide, yes. So why is this grade 4 when there are other pediatric tumors also being IDH wild type and H3 wild type, but it's still grade 1? And these other pediatric tumors, as I said, are astrocytoma, MAPK pathway altered, and the other one, the MYB and MYBL altered. So that is because these ones have only one problem. You don't have to remember or understand this entire table here. I included it because a lot of people go back to the PPT and then it's easier if there is comparison. So if this slide overwhelms you, it's completely okay. We are not supposed to remember all of it. But what happens is these tumors, the MAPK altered ones, they have one problem or probably two problems, which is IDH wild type and H3 wild type. While these tumors, they have a lot of problems, especially the mycin amplification, EGFR amplification. These are these are problems, these are molecular profiles which biologically upgrade the tumor to higher grades because they make the cell divide crazily, right? And then there is another thing, CDKN2A and CDKN2B deletion. Anyone else remembers where this came up?
Yes, sir.
Astrocytoma.
Yes,
Yes.
astrocytoma
Astrocytoma.
grade 4. And another one. There was another one. Oligo.
Oligodendroglioma.
Yes, yes, oligodendroglioma. Uh, so anywhere where CDKN2A and CDKN2B come up, there is homozygous deletion. Those tumors are automatically upgraded to grade 4, or if grade 3 is the highest grade, then grade 3, because for ODGs, grade 3 is the highest, right? So TP53 mutation, CDKN2AB deletion, these are present in this H3 IDH wild type, and hence they make the DNA very, very unstable. The DNA is messy, the cell is embryonic like, it keeps on dividing, and hence the tumor becomes high grade, grade 4, despite having some portion of it similar to MAPK altered. So, a very simple rule of thumb in pediatric neuro-oncology, if any diffuse glioma has a CDKN2A or CDKN2B homozygous deletion, it is almost certainly going to behave like a high-grade tumor, regardless of whether it is IDH or H3 wild type. Now, this is completely different than the adult population, where IDH wild type is essentially a diagnosis of grade 4. So, it's very important to remember the pediatric neuro-oncology and the adult neuro-oncology, and especially in the patients which are at the border, as in 2021, anyone younger than 25. These are the borderline or the overlapping age groups in which you might find the adult prototypes, but you might also find the pediatric prototypes. So let's go back to the basics. These are WHO grade 4 tumors, and primarily in children and adolescents, although it can also occur in young adults, predominantly supratentorial, can involve either lobe. There are three molecular variants, and mycn, RTK1, RTK2. It's completely okay if you don't remember all of these. Just remember that RTK2 has a slightly better prognosis. There's rapid onset of symptoms due to fast growth. There can be severe headaches and vomiting, increased intracranial pressure. There can be focal deficits, hemiparesis, sensory loss, seizures, and the imaging is very much suggestive of a high grade lesion. So, this is not a chameleon in terms of radiology, this is a clear cut high grade diagnosis. We see that this is T2 weighted image, axial sections, MRI brain plane, and the lesion is heterogeneously hyperintense. And we see some phloids in the middle, which shows that there is a lot of blood loss that can happen during the surgery. We see that this is diffuse and it is involving eloquent regions. We cannot completely take it out. And you see the same on the flare. It's still hyper intense on the flare as well. Also, a lot of you I have noticed confuse flare and T1, right? What happens is, if you see the cortex is going to be very similar in T2 and flare. The white matter is gray, the gray matter is whitish, and that is how you know that this is a T2 sequence where CSF has been subtracted. On T1 weighted images, you would say that the gray matter is gray and the white matter stays whitish, as in. So, if you remember T2, you just have to look for similar anatomy here and only think of CSF as the black. So, this is hyperintense on flare as well. And this is DWI. We see some form of diffusion restriction, and the last sequence is something that I have also forgotten. If somebody else knows, they can comment. Otherwise, we can always go back and look at it. Can someone else comment on F?
Diffusion weighted image, ma'am.
I'm not sure. I'm not sure, but I would go and check, and then maybe we can come back to it in the later session, inshallah.
Here,
So,
It's
yes,
I think
Dr.
it's
Mangal?
like T2 weighted images for hemorrhage, like GRE or T2 star or SWE.
Yeah,
That's why it shows the blood as hypointense. It's CSF is white, so it's
yeah.
T2 weighted, showing hemorrhage and blood vessels more very dark. So I think it's T2 GRE or SWE.
Could be. I am not sure. I can go back and check. So we have a very similar pairing tumor here, which is diffusely infiltrating. We see that it is heterogeneous intensity, both hypointense, hyperintense. Some regions are isointense as well on T2. This is diffusely infiltrating. If you see that this is involving the centrum semiovale as well. This region is centrum semiovale, and there is effacement of the ipsilateral ventricle here. There is significant mass effect as well. And you see the corresponding lesion on T1 here as well. And this signifies intratumoral hemorrhage. Okay. And if you see post contrast, the uptake is not enough. Uptake is patchy. Also, these tumors, they take up contrast, but it varies from patient to patient. Sometimes they enhance densely, sometimes they don't enhance, or there is patchy enhancement. So always remember, enhancement is not the rule of not enhancing does not always mean that it's a benign lesion. So, radiologically, they are large, poorly marginated, infiltrative masses, and inhomogeneous enhancement is there, sometimes rim enhancement is there. On TWI, they show restricted diffusion, and that is because the solid components are very high in cellularity. We have already discussed this, and I would advise all of you to go back and look at the PPT and try understanding the entire slide, even though I have conveyed the basic idea behind it. So, moving on to treatment and prognosis. Surgery, maximum safe resection is still our goal. It is the strongest predictor of improved survival, but we already saw the images that the lesion is very diffuse, it's infiltrating, and it is not always possible to get it out completely. So, we go for MSR instead of GTR and try to get out whatever we can. And then we have postoperatively radiotherapy, which is a standard of care for children over age 3. Under age 3, we avoid radiotherapy in children because the brain is going through very rapid development. So, the neurocognitive side effects of radiotherapy are very, very prominent in patients under the age of 3 years. And this is the age group where we use chemotherapy mostly. TMC can be given even though its efficacy is not proven, and there are some trials going on according to the targeted therapy. And let's see the prognosis. The median overall survival is approximately 14 to 17 months for the MYCN and RTK1 subgroup. And as I mentioned previously, RTK2 group has a slightly more favorable, even though still poor median survival of up to 44 months, roughly three and a half to 4 years. So that's it. That's a wrap for today. Any feedback, any questions, they are welcome. I have left a poll on the group in terms of timing, because a few people have messaged me saying that 4 p.m. is consistently going to be a problem for them because they're working at that time. So do leave your vote on the group and let's see if we can adjust the session time. Any feedback?
Yes, Dr. Kaul, I want to discuss what actually happens in ward is during our ward, especially the diffuse midline glioma, we do take stereotactic biopsy from them, but our consultant says that there is no outcome as such, so let's not give any more trauma to the patient. So, in terms of practicality and notebook, as I know that everything that you are saying is from the literature, but practically speaking, what's your view on that?
Okay, where are you working, Dr. Ahmad? Just out of curiosity.
Yes, it's Khyber Teaching Hospital in Peshawar.
Okay, brilliant. So I did my residency in LUMS, Hyderabad, and yes, I get that. I get the resource constraints. I get the concept of when you cannot give any benefit to the patient, why even go through the biopsy route? I get that. And problem is we work in resource limited setups. We don't have clinical trials going on. We don't have a lot of other good options that the patients outside Pakistan have because they have dedicated neuro-oncology groups, neuro-oncology wards, right? And even if the same patient is referred to a good setup, I don't want to take names, they would be treated differently. As far as we are concerned, from a practical point of view, yes, it makes sense to not do the biopsy. It's good if you people are even doing a stereotactic biopsy. In my unit, I saw them managed by, we used to just manage the hydro, and then we sent the patient to the oncology setups, referring them with the saying that this is a midline glioma and proceed with the radiotherapy. That is okay. We have practical constraints, but you should still know what is going on in the world and what is the future. So the answer doesn't change. Our practice might change because the people who are making these guidelines don't work in LMICs, unfortunately. So that might change, yes. The practice and the guidelines will have to differ here. I get that. I completely get that. But maybe in a few years, if radiomics becomes commonplace in probably 5 to 10 years, that would be the new norm instead of stereotactic biopsy as well. Anyone else?
Thank you, Dr. Kaul.
No, that's completely okay. So we are going to proceed with tumors as everybody voted on the group. I see that all of you like it just as much as I do. So let's see tomorrow, inshallah. We will wrap up the infant high-grade glioma and then we will move on to, I'm not sure, I have not decided what next tumor is going to be. Okay, that's a wrap, everyone. Thank you so much for joining.
Thank you, Ma.
Thank you.
Thank you.